Welcome to the deep dive. This is where we sift through, mountains of research, excerpt notes, all that complex stuff, and we boil it down into knowledge you can actually use, like right away.
Mm.
And today we're doing a really critical deep dive, one that's specifically for new parents, or maybe you're expecting. We're looking past the immediate chaos, the diapers, the lack of sleep.
Yeah, the survival mode.
Exactly. We want to look at the hidden architecture, the stuff happening underneath. Our mission today is to pull out the essential structural knowledge. We're talking about the link between how your baby feeds, how they breathe, how they sleep, and, well, their health for their entire life.
Right. It's about finding those crucial levers you can pull, especially in these early days, that can genuinely shape their future development.
And when you say shape, you mean that quite literally, don't you?
Oh, absolutely. We're
Yeah.
talking about like structural engineering for the face and airway. This
Yeah.
isn't just about, eat your veggies. This is about growth modification. It's prevention. The sources we looked at really hammer home this concept. And it should stop every new parent in their tracks. It's at the first few years, say 0 to 4, maybe even up to 12, that window. That's your biggest opportunity.
The biggest window for what exactly?
For influencing your child's airway development and their craniofacial structure, how their face actually grows. Get this statistic, one expert pointed out, that a full 60% of the face, like the jaws, the whole mid-face structure, develops by age 4.
60% by 4. Wow.
Yeah, and then 90% is basically set by age 12.
That's just incredible. It's this massive developmental sprint, and it's happening while we're just trying to figure out how to, master the swaddle or deal with colic.
Right. We're focused on milestones like sitting up or crawling, which are important, of course, but underneath all that, the literal scaffolding for their adult jaw, their teeth alignment, and critically, their breathing passages. That's all being built right then.
And it's not just genetics deciding how that scaffolding looks.
No, that's the key takeaway. It's built based on function. How they use their mouth and airway dictates how the structure forms. So if the function is off, say, the tongue rests low in the mouth, or the baby breathes through their mouth a lot.
Then the structure follows that faulty pattern.
Exactly.
The structure will inevitably develop incorrectly. So our hook for you, the listener, is really this empowering idea. If you're informed about this stuff early on, you can proactively work to help your baby become a strong, consistent nasal breather with a healthy jaw structure to support that.
Precisely. A wide, healthy jaw. And taking these steps significantly cuts down the risk of needing, well, some sources called it crazy artificial expansion stuff later on.
Things like braces, expanders.
Yeah, complex orthodontics, even jaw surgery in some cases, or, and this is huge, treatment for chronic sleep disorder breathing as they get older. We're really talking about setting the stage for better sleep, better brain function, fewer respiratory issues long term.
Okay, let's dig into that core idea then. The tongue. You said it shapes the face. How does that work? How does the tongue affect, the width of your jaw?
It's pretty amazing, actually. The tongue is essentially the body's own natural orthodontic device. Think of it as the built-in palate expander.
A natural expander.
Yeah.
It's the force that guides how the upper jaw, that's the maxilla, develops. So the core principle for healthy facial growth is this. The tongue needs to be suctioned up gently but consistently against the entire roof of the mouth, like a constant light pressure upwards.
Exactly. That's the natural state. Sometimes people refer to it as mewing in adults, but it starts here. When the tongue is in that correct position, that persistent upward pressure pushes the maxilla, the upper jaw, up and also forward.
Okay.
And that encourages the development of a nice wide U-shaped dental arch. It promotes that forward growth of the whole mid-face.
So it's like an internal scaffold director, making sure there's enough room, pushing things out and forward, which would mean more space in the nose and airway too, right?
Absolutely. That's the positive path.
Right.
But what happens if that mechanism gets disrupted? Maybe the baby's congested a lot, or there's a structural issue like a tongue tie, or they just develop a mouth breathing habit.
Yeah, what's the downside?
Well, that's the detrimental path we really want to try and counteract. If the baby defaults to breathing through their mouth, even just some of the time, the tongue automatically drops. It rests low on the floor of the mouth.
And that removes the upward pressure.
Completely removes it. So instead of that up and forward growth, the face tends to develop, as one source put it, in a melted down and back fashion.
Melted down and back? That sounds not ideal.
It's not. Medically, you might hear terms like mid-face hypoplasia. Basically, the middle part of the face doesn't project forward like it should.
And what does that actually look like long term? What are the physical results?
Well, structurally, it's a cascade of issues. Without that outward push from the tongue, the palate, the roof of the mouth, it often becomes really high and narrow. It forms more of a V shape instead of that broad U.
Okay, I can picture that. Narrower roof.
Right. And that narrowness directly reduces the space inside the nasal passages, which, guess what? Makes nasal breathing harder and encourages more mouth breathing. It's a cycle.
Ah, okay.
And at the same time, because the upper jaw isn't growing forward properly, it holds back the lower jaw, the mandible, from growing forward too. So you end up with an underdeveloped lower jaw, often recessed.
Which leads to crowded teeth.
Guaranteed.
Mm.
Severe crowding is almost inevitable because there's just not enough space in the jaw for all the adult teeth.
Nice.
So yeah, future orthodontics become a near certainty. And critically, this whole pattern compromises the airway.
How does it compromise the airway?
Because the tongue, now stuck in that narrow, high space, doesn't have anywhere to go but backward, especially during sleep. It falls back and obstructs the throat.
So if you're a listener whose older kids maybe needed, like, a palate expander, an RPE.
Exactly. Those devices, those rapid palatal expanders, they become necessary later because the natural expander, the tongue, didn't get to do its job during that critical growth window in infancy. If you can help your baby achieve consistent nasal breathing early on, keeping that tongue up against the palate, they essentially get the benefit of a natural RPE right from birth.
And that foundation, that structure, is key for preventing sleep apnea later.
It's probably the single biggest factor.
Yes.
A wide, forward-growing facial structure provides the maximum possible space for the airway and helps prevent that tongue collapse during sleep, which is the hallmark of obstructive sleep apnea, OSA.
So nasal breathing sounds absolutely critical, but you also mentioned newborns kind of struggle with this. The sources said their airways are vulnerable.
Yeah, it's a bit of a paradox. It's like they're designed for nasal breathing, but also designed to have trouble with it initially. It's a challenge of their anatomy during rapid growth. Newborn tissues are just incredibly soft, weak, and pliable.
Floppy.
Floppy is a great word for it. The structure supporting the airway, the larynx, the trachea, they're inherently collapsible. Medically, you might hear about mild laryngomalacia, which is actually really common and often describes this floppiness. Their skeleton is still mostly cartilage.
One of the parents in the sources said their baby sounded like a pug, even with their mouth closed.
That's a perfect description. It captures that sound of soft tissues vibrating or partially collapsing during breathing. It reflects that internal weakness.
And because breathing is, the body's absolute top priority,
A prime directive, yeah.
this floppiness can lead to the baby finding quick fixes, or what you called maladaptations.
That's right. If the nasal passage feels tight or constricted, maybe because of that anatomical floppiness or a bit of swelling or normal newborn congestion, the baby's instinct, their survival reflex, is to just drop the jaw and open the mouth to grab air more easily.
Makes sense as a quick fix.
It does. But if that temporary fix becomes the habit, it immediately forces the tongue down, and boom, you've started that negative cycle of facial development we just talked about.
So our job as parents who know this now is to understand that fragility and use everything we can, environment, feeding, to encourage and basically enforce nasal breathing as much as humanly possible right from the start.
Exactly. Minimize the chances for that maladaptation to take hold.
Okay, that leads us perfectly into the most critical environmental control we have, which is safe sleep. Given how vulnerable and floppy that newborn airway is, the guidelines from the American Academy of Pediatrics, the AAP, they're not just suggestions, they're really about protection.
Absolutely. These guidelines are built on just decades of research, primarily focused on cutting the risk of SIDs, sudden infant death syndrome, which, peaks during that period when the airway is most vulnerable.
Let's break down the ABCDs then, maybe adding a bit more depth to why each rule is so important. A is for alone. Baby must sleep alone in their own safe space, like a crib or a bassinet. Why is bed sharing such a risk, even if a parent feels like they're being super careful?
Yeah, this is a tough one sometimes emotionally, but the risks are real and tragically preventable. There are a few dangers. First, there's the risk of overlaying a parent, especially if very tired or maybe took medication, could accidentally roll onto the baby. Second, adult beds are dangerous environments. Soft mattresses, pillows, duvets, blankets. These are immediate suffocation hazards for an infant who can't move away from them.
Right, they can't push a pillow off their face, exactly. And third, babies can get trapped between the mattress and the wall, or the mattress and the headboard or footboard. The sources were really clear. Even putting twins together in one crib or having an older sibling share the bed, it introduces unacceptable risks of suffocation or entrapment. Alone means truly alone in their space. Okay, B is for back. Always place the baby flat on their back for every single sleep. Naps, nighttime, every time. This was the heart of the Back to Sleep campaign, right?
It was, and it dramatically reduced SIDs rates. But parents still worry, especially about spit up or reflux. They think, won't my baby choke if they're on their back and spit up?
Yeah, that's a common fear. What's the reassurance there?
The reassurance comes from anatomy and reflexes. Baby's windpipe, the trachea, actually sits above the food pipe, the esophagus, when they're lying on their back. So if they do spit up, gravity naturally pulls the liquid in the lower part of the throat, away from the airway opening, which is positioned higher up.
Ah, okay.
And healthy babies have incredibly strong gag and swallow reflexes that automatically clear anything that gets near the airway. When a baby is on their stomach, however, any spit up pulls right around the airway opening, making it much harder to clear. So back sleeping actually keeps the airway safer and more open.
That makes sense. Okay, C is for crib, or a safe sleep surface. It has to be firm and flat, no give, no indenting, and absolutely no inclined sleepers, rockers, car seats for sleep, especially anything tilted more than about 10 degrees.
Right. Firmness is key because a soft surface can actually mold around the baby's face and trap carbon dioxide, basically creating a little pocket of exhaled air they rebreathe. Plus, a firm surface gives proper support to their spine and helps maintain that open, floppy airway structure.
And the incline issue leads us to that bent straw warning you mentioned.
Exactly. We'll get right back to that because it's critical, especially when dealing with congestion.
Got it. And finally, D is for don't smoke. This feels obvious, but it needs hammering home.
Absolutely non-negotiable. Exposure to any kind of smoke, tobacco, marijuana, even vaping fumes. It damages the delicate little hairs, the cilia in the baby's respiratory tract that help clear mucus. It causes inflammation, narrows the airway.
And increases SID's risk.
Dramatically. It just compromises their ability to cope with even minor congestion or respiratory challenges. The baby needs a completely smoke-free environment, period. No exceptions.
Okay, so beyond the ABCDs, let's talk about the crib environment itself. The saying is bare is best. What does that mean in practice?
It means the crib should contain only the baby, a firm mattress, and a tightly fitted sheet over that mattress. That's it.
No bumpers, no blankets.
Nothing soft or loose. No pillows, no blankets, no quilts, no crib bumpers. Those are a huge strangulation and suffocation risk. No weighted swaddles or sacks. Not even stuffed animals, really, especially when they're very young. Parents often want the crib to look cozy and inviting.
Yeah, you see those pictures online with lots of stuff in the crib.
Right, but those are staging photos,
Yeah.
not safe sleep environments. Anything soft introduces a risk because the baby simply lacks the strength or coordination to move it away if it covers their face or gets tangled around them. Bare really is best for safety.
We should also clarify room sharing versus bed sharing. They sound similar but are very different in terms of safety.
Crucial difference.
Yeah.
Room sharing means the baby sleeps in their own safe space, their crib or bassinet, but in the same room as the parents. This is actually highly recommended.
Why is it recommended?
Well, it makes monitoring easier, feeding is more convenient, and importantly, studies show it can reduce the risk of SIDs by up to 50%. The recommendation is generally for at least the first 6 months, ideally the first year.
But bed sharing, having the baby in the parent's bed, that increases the risk. Significantly increases the risk for all the reasons we discussed: overlaying, suffocation from bedding, entrapment. So room sharing, good. Bed sharing, dangerous.
Okay? And temperature. Overheating is a risk factor too.
Yes, overheating is a definite SIDS risk. It seems to make it harder for babies to arouse themselves from a deep sleep if something is wrong, like if their breathing is compromised.
So how do you gauge the right temperature?
The general rule of thumb is to dress the baby in one more layer than what an adult would find comfortable in that same room. And definitely use a wearable blanket or sleep sack instead of any loose blankets.
And no hats indoors.
Right. Once you're home from the hospital, no hats indoors for sleep. Babies regulate their temperature largely through their head, so covering it can easily lead to overheating.
One last thing on the sleep environment, pacifiers.
Ah, yes, the pacifier. Offering a clean, dry pacifier when you put the baby down for naps and nighttime sleep has been shown to reduce the risk of SIDs.
Do we know why? The exact reason isn't totally clear. Theories range from it helping to keep the airway slightly more open by positioning the tongue forward, or maybe it keeps them in a slightly lighter stage of sleep, making them easier to arouse.
Should you wait if you're breastfeeding?
Yeah, the usual advice is to wait until breastfeeding is well established, maybe around 3 to 4 weeks, just to avoid any potential nipple confusion early on. But after that, it's considered a protective tool. And if it falls out after they fall asleep, you don't need to put it back in.
Okay. Now, let's loop back to congestion and that bent straw warning. Newborns have to breathe through their noses, mostly. So a stuffy nose is a huge deal for sleep and feeding.
It really is. It can disrupt everything. And the parent's immediate instinct, understandably, is often to try and elevate the baby's head, thinking it will help them breathe easier, like it does for us adults sometimes.
Right, propping up the mattress or letting them sleep in a car seat or a swing.
And this is where it gets dangerous. That instinct is wrong for babies. Remember the floppy airway and weak neck muscles? Well, an infant's head is really heavy compared to their body. When you put them on an incline, their head naturally tends to slump forward, tucking their chin down towards their chest.
Okay, I can picture that.
That position physically kinks their soft airway, just like bending a straw. It actually makes breathing harder, not easier, and increases the risk of airway obstruction or even suffocation. It restricts airflow significantly.
So even if they're sick and congested, they must sleep flat on their back.
Must. Always flat on the back on a firm surface. No exceptions, even with a cold. Elevation is not the safe solution for infant congestion during sleep.
So if you can't prop them up, what are the safe ways to manage that congestion so they can breathe through their nose, feed, and sleep?
Okay, safe relief involves a few steps. First, saline. Use sterile saline drops or a gentle spray in each nostril to help loosen up and thin the mucus. Wait maybe 30 seconds or so.
Okay. Second, gentle suction. Use a nasal aspirator or a bulb syringe, but technique matters here. Squeeze the bulb before you put the tip gently into the nostril, then slowly release the bulb to suck the mucus out. Don't squeeze air in, right? Squeeze out first, then insert, then release.
Exactly. Third, humidity helps a lot. A cool mist humidifier running in the room keeps the air moist and helps prevent the mucus from getting thick and sticky. Just make sure you clean it regularly to prevent mold.
Good point.
And finally, hydration is key internally. Make sure the baby is getting plenty of fluids, breast milk or formula. Keeping them well hydrated helps thin secretions from the inside out.
Okay, that makes sense.
Okay.
Saline, suction, humidity, hydration. But when does simple congestion cross the line into something more serious? What are those emergency signs, the 911 signs? Parents absolutely need to know for respiratory distress.
Yeah, knowing the red flags is crucial. You need to call 911 or get to an emergency room immediately if you see any of these. Your baby is visibly struggling for every single breath, making loud grunting sounds, especially when they breathe out. Okay, if they seem unable to cry or make normal sounds, any blue or purple color around the lips, on the face, or the tongue, that's called cyanosis, lack of oxygen. Or, and this is a big one, chest retractions.
What are retractions?
That's when you see the skin getting sucked in sharply with each breath, either at the base of the neck, above the collarbones, or between the ribs or under the rib cage. It means they're using extra muscles just to try and pull air in, and the airway is significantly blocked. They're working way too hard and towering out fast.
Those are the immediate emergency signs. What about signs that warrant a call to the pediatrician, maybe not 911, but definitely need checking out?
Right, call your pediatrician right away if the baby is breathing consistently fast. You'd need their guidance on what's fast for your baby's age, but definitely faster than usual. If they have a cough that's bad enough to interfere with feeding or sleeping, or if they have any fever, especially over 100.4 degrees Fahrenheit or 38 Celsius in a baby under 2 months old, fevers in very young infants always need medical evaluation. Okay, so moving from the sleep environment, let's talk about function again, specifically feeding. This is really the second major active pillar we can influence for that craniofacial development we've been discussing.
And we need to think of it not just as getting calories in, but as
an intense repetitive workout for the mouth, jaw, and tongue muscles. It's happening, 6, 8, maybe 12 times a day in those early months. Each feeding session is actively shaping the structure.
The sources really highlighted a difference here, framing breastfeeding as like nature's built-in myofunctional therapy tool, inherently better for development than traditional bottle feeding. Can you break down that mechanical difference?
Yeah, the mechanics are fundamentally different, and it has direct consequences for facial growth. Breastfeeding isn't passive. The baby has to work. They need to create and maintain a really strong vacuum seal with their lips and tongue.
Okay.
To get the milk out, they have to use their whole tongue in this complex, wave-like motion peristalsis, drawing the nipple deep into their mouth. They use their jaw, rhythmically moving it up and down. It requires significant effort, coordination, and muscle strength.
Then the breathing connection.
Critically, because the tongue has to be held high and wide against the palate to maintain that vacuum seal, it's physically impossible for the baby to breathe through their mouth while they're actively latched and swallowing milk effectively.
So if they try to mouth breathe, the milk stops.
Exactly. They lose the seal, lose the vacuum, milk flow stops. Breastfeeding essentially forces nasal breathing during the feed, and it reinforces that high tongue posture that shapes the palate.
Wow. So it's doing double duty, shaping the structure and training the correct breathing habits simultaneously. But that sounds like hard work, and bottles often deliver milk much more easily. Why would a baby stick with the harder option at the breast?
Well, that's where the sources talked about the soul food factor. It's more than just milk volume. The baby's deeply wired for survival, and that includes connection and security.
Okay. The motivation to do that work comes from the whole experience. The skin-to-skin contact, the warmth, hearing the parent's heartbeat and voice, the eye contact. That intense intimacy makes the effort feel safe and rewarding. It triggers their deepest instincts for survival and bonding, and that effort, that workout, is what sculpts the jaw.
Precisely. That constant, vigorous work, the tongue lifting and spreading, the jaw moving rhythmically, directly encourages the palate to grow wide into that ideal U shape. It also helps stimulate the lower jaw to grow forward correctly. It's really the kickstarter for the healthy facial development pattern we want.
And you mentioned earlier this workout might also help with that initial floppy airway problem.
Yes, exactly. The sources suggested that sticking with that vigorous suckling action, typically well established through consistent breastfeeding for maybe 4 to 6 months, actually helps the muscles and tissues in the throat and larynx mature and stiffen up. They become less collapsible.
So that pug-like breathing sound might actually resolve as they get stronger through feeding.
Often, yes. When those muscles are getting a regular, intense workout, the whole structure tends to firm up naturally. This then reduces the chance of the baby falling back into mouth breathing, just because their airway feels weak or unstable.
Okay, but breastfeeding isn't always possible or chosen. Many families use bottles with formula or pumped milk. So how can they optimize bottle feeding to try and mimic some of those developmental benefits and avoid the pitfalls?
Right. And it's important because conventional bottle feeding can be problematic developmentally. The main issue is that it's often too passive.
Milk flows too easily.
Yeah, often the milk flows very fast just from gravity and the nipple hole size. The baby doesn't have to work for it. And frequently, with standard rigid nipples, babies learn to use compression rather than vacuum. They use their cheek muscles. You see that kind of fish face sucking motion.
Right, pinching the cheeks in.
Exactly.
Mm.
And that action can actually exert inward pressure on the jaws, hindering that outward transversal growth we want for palate width. So optimizing bottle feeding means tackling both the equipment and the feeding technique.
Okay, let's start with equipment. Nipple shape and flow rate.
For nipple shape, generally something cylindrical or round with a gradual slope is often recommended, as it might encourage a deeper latch, more similar to the breast. But the absolute most critical factor is the flow rate.
Slow flow.
The slowest flow possible. You want to start with what's typically labeled a level 0 or preemie flow nipple, regardless of your baby's age or weight initially.
Why so slow?
Because the slow flow forces the baby to actually work. They have to generate some suction and actively coordinate sucking, swallowing, and breathing. If the flow is too fast, they just gulp, swallow a lot of air, might choke or sputter, and they completely miss out on that crucial oral workout.
So don't just automatically move up a nipple level because the package says 3 months plus.
Definitely not. Only consider moving up a level if the baby is genuinely showing consistent signs of frustration, like taking way over 30 minutes to finish a bottle, getting exhausted, or constantly collapsing the nipple because they're sucking so hard against too slow a flow. Age alone is not the reason to upgrade. Slow is generally better for development.
Okay, slowest flow possible. What about the technique? You mentioned paced bottle feeding. How does that work?
Paced bottle feeding is a technique designed to mimic the baby's control and the effort level of breastfeeding. It involves a few key things. First, hold the baby more upright, not lying back flat. This lets them manage the flow rather than having milk just pour down their throat from gravity.
Yes.
Second, hold the bottle horizontally, parallel to the floor. Only tilt it just enough so that milk fills the very tip of the nipple. This means the baby has to actively suck to draw the milk out rather than having it flood their mouth.
Okay, horizontal bottle, slight tilt. Third, let the baby initiate the feed. Don't just push the nipple in. Touch it to their lips, let them open wide and latch on themselves. And fourth, The pacing part. Every 20 or 30 sucks or so, gently tilt the bottle downward, breaking the seal at the corner of her mouth slightly. Why do that?
It gives them a mandatory pause, a moment to take a calm, full breath through their nose. It prevents that frantic gulping and helps them learn to coordinate breathing with swallowing, just like at the breast. It slows the whole feed down to a more natural, manageable pace.
All right, that sounds like a really practical way to make bottle feeding more active. Now, we also need to touch on potential structural roadblocks, things like tongue ties and lip ties, often called tethered oral tissues or TOTs.
Yes, TOTs. These are basically bands of tissue, the frenulum, under the tongue or upper lip that might be unusually short, tight, or thick, restricting movement.
And the sources emphasize it's not just about having a tie, but whether it actually causes a functional problem.
That's the crucial shift in thinking. Pretty much everyone has these frenulas. A tie is only considered problematic if it genuinely restricts the function of the tongue or lip in a way that impacts feeding, and potentially later, speech or breathing.
What are the signs of a functional restriction?
For infants, signs might include a really weak suck, difficulty latching or staying latched, making clicking sounds while feeding that often means they're losing the vacuum seal, swallowing a lot of air, which can lead to excessive gas, fussiness, colic-like symptoms, or even reflux. And for the breastfeeding parent, significant nipple pain or damage can also be a sign.
And how does a restricted tongue link back to the facial development we've been talking about?
It's a direct link. If the tongue is physically tethered and can't lift up fully or move side to side properly, it cannot perform that essential job of resting against the palate and providing that gentle, outward shaping pressure.
So it's forced to rest low.
Exactly. A restricted tongue often defaults to a low resting posture. And as we've established, a low tongue posture is a primary driver for developing a high, narrow palate, which then restricts jaw growth and compromises airway space down the line.
So getting that assessed early is important if there are feeding issues.
Yes. If there are functional concerns with feeding, getting an assessment from someone experienced in TOTs, like a knowledgeable pediatric dentist, an IBCLC lactation consultant, or perhaps a myofunctional therapist is really important. Addressing a functionally significant tie early can potentially remove a major roadblock to proper facial and airway development. Okay, moving beyond feeding mechanics, let's talk about proactive development through movement and later texture. We touched on the Back to Sleep campaign, saving lives by having an unintended side effect, more flat spots on babies' heads. Right, positional plagiocephaly, that flattening on one side, or brachycephaly, flattening across the back. It happens because the infant's skull is still really soft and malleable, and if the baby spends too much time with pressure on the same spot, the skull can mold to that pressure.
So since babies must sleep on their backs for safety, we need a counter strategy during waking hours.
Exactly. This is where the concept of a 24-hour plan to prevent flat spots comes in. And the absolute cornerstone of that plan is supervised tummy time. Or, as the sources really push for, thinking of it as tummy to play.
Why tummy to play?
Just to frame it positively, it's not a chore. It's a crucial part of their development and playtime. And it's about way more than just preventing a flat head shape.
Right. What else is that tummy time workout achieving?
Oh, it's a fantastic all-around workout. It strengthens the muscles in their neck, their shoulders, their upper back, their core. These are all essential precursors for hitting later motor milestones like rolling over, pushing up, sitting independently, and eventually crawling.
And how does it tie into the facial and jaw development we're focusing on?
Crucially, tummy time strengthens the muscles under the chin, the submental muscles, and the muscles that support the jaw. Lifting their head against gravity encourages the jaw to move forward and down, helping to reinforce that proper positioning and growth pattern we want.
Okay. The recommendation is often to aim for about an hour total per day by around 2 months old. That can sound daunting for new parents.
It does, but the key is that it's cumulative. It's not one solid hour block. The sources strongly advise starting right from day one, literally the day you get home from the hospital, with just very short sessions, maybe only 1 to 3 minutes, several times a day.
Short bursts.
Yeah. Short, frequent bursts. Maybe after every diaper change, lay them on their tummy on a play mat for a minute or two, or let them lie tummy down on your chest while you're reclined on the sofa. Integrate it into the routine. Aim for maybe 15, 30 minutes total spread throughout the day by around 7 weeks, and then gradually build up towards that hour goal.
And besides dedicated tummy time, maximizing positional variety throughout the day is also key.
Absolutely vital. Think about how much time a baby spends lying down. If they always lie the same way, pressure stays in the same spot. So simple things help. When you put them down in the crib, alternate which way their head is facing. Babies often turn towards light or activity, so switch ends of the crib sometimes. Alternate which arm you hold them in for feeding or carrying. If you always hold them in your left arm, they might always turn their head to the right, leading to flattening on the left side of the back of their head, or even muscle tightness in the neck, called torticollis.
And limit time in containers?
Yes. Minimize the time spent in devices like car seats, outside of the car obviously, swings, bouncy seats, strollers where they're reclined. Use them for their intended purpose travel, a short period of safe containment, but not as places for extended naps or hangouts. A developing flat spot can actually be a sign that the baby isn't getting enough variety of movement and positions, spending too much time immobilized.
Okay, so lots of varied movement, lots of tummy time. Then, as the baby gets older, around 6 months or so, feeding shifts again. It's not just about sucking anymore, it's about chewing.
Right. And this transition to solid foods is the next major workout opportunity for the jaw and facial muscles. This period is absolutely critical for mandibular or lower jaw growth,
Why is texture so important here?
because chewing different textures is what builds muscle strength, coordination, and endurance in the jaw, tongue, and cheeks. It's essential for developing mature chewing patterns, which are needed for clear speech development later on, and importantly, for stimulating continued bone growth.
So just sticking with smooth purees for too long is a bad idea.
It really is. Purees are just a very temporary starting point. If a child stays on a diet of only soft, smooth foods for an extended period, their jaw muscles don't get the necessary workout. They essentially develop what some call a liquid diet jaw. The muscles can atrophy, and growth can stagnate simply from lack of use and stimulation.
So the progression needs to happen reasonably quickly.
Yes. Move from those thin, smooth purees to thicker, lumpier, mashed textures fairly soon. Think mashed avocado, thicker oatmeal with some lumps, mashed banana. Then introduce soft, dissolvable solids they can gum or munch on, like puffs or soft teething crackers.
And then the step that's often missed.
The hard diet. This sounds counterintuitive, maybe even scary to parents worried about choking, but introducing harder textures for gnawing and scraping is essential.
Why hard?
Because actively chewing and gnawing on resistant foods actually stimulates the periodontal ligaments, the little fibers that hold teeth in the jawbone. That stimulation sends signals to the bone itself, telling it, hey, we need to grow stronger and bigger here. This is crucial for the jaw to grow long enough and wide enough to eventually accommodate all the permanent teeth without crowding.
Okay, but choking is a real fear. What are safe examples of this hard diet for a baby, say 6 months plus?
Supervision is key, always, but safe examples for gnawing include things like a whole, peeled raw carrot stick. It's too hard for them to bite off a dangerous chunk, but it's perfect for them to hold, scrape with their gums, and really work those jaw muscles. Or maybe a large, hard crust of bread they can gnaw on. A soft, cooked piece of meat still attached to a large bone, like a lamb chop bone or a chicken drumstick joint, making sure the bone is too large to swallow and the meat is secure, so they're just gnawing the surface. Even something like a large stalk of celery may be chilled.
So the idea is they scrape and gnaw, but can't easily break off a piece that could block the airway.
Exactly. It's less risky in some ways than, say, a soft chunk of banana or avocado that could be accidentally inhaled. With these harder items, the baby self-regulates. They get the muscular workout, they practice the side-to-side jaw movements needed for mature chewing, but they're unlikely to break off a piece big enough to choke on, especially with supervision. Patience is needed, they might not consume much, but the workout is the goal.
All right, this brings us towards the end, thinking about prevention and early action. Let's outline those intervention windows. What are the clear red flags parents should be watching for, especially in those early years, say age 1 to 4, that would signal, okay, maybe we need to consult a specialist?
Yeah, we want parents to become good observers of function long before they ever worry about crooked teeth showing up years later. Early intervention, ideally between 1 and 4, maybe up to age 7, is when you can still guide growth much more easily.
So what's on the checklist? Okay, number 1, chronic mouth breathing. Are their lips usually apart when they're at rest, watching TV, playing quietly, sleeping? Healthy resting posture is lips gently together, breathing through the nose. If the mouth is open, the tongue is down. That's a red flag.
Ugh.
Okay, lips apart at rest. What else?
Snoring or any unusual noises during sleep. Snoring, gasping, choking sounds, these are never normal in a child unless they have a really bad cold at that moment. Consistent snoring indicates some level of airway obstruction and needs investigation. Also, listen for frequent waking, restlessness, or weird popping or clicking sounds during sleep.
Got it. Snoring is not normal.
difficulty with swallowing or coordinating eating. This could look like persistent, excessive drooling well past the normal teething stage, maybe frequent gagging or choking, especially as textures advance, difficulty managing different food textures in their mouth,
Okay. And number 4.
open lip posture, or a tongue thrust. This relates back to mouth breathing, but even when awake, do their lips just seem to hang open? Does it look like they have to make a real effort to close their lips? And watch how they swallow or even talk. Do you see the tongue pushing forward against or between their front teeth?
Ew.
That's a tongue thrust, an immature swallow pattern that pushes teeth out and hinders proper jaw growth.
So if parents see any of those signs consistently, the mouth breathing, snoring, swallowing issues, tongue thrusts, that's the time to seek advice.
Yes, consult with a specialist who understands these connections. That might be a pediatric dentist trained in airway issues, an orofacial myofunctional therapist, OMT, maybe a pediatric ENT, or even sometimes a chiropractor or osteopath specializing in cranial work.
Because catching it early, say between 4 and 7, allows for interventions that can actually guide the growth correctly.
Exactly. In that window, you can often use relatively simple functional appliances, exercises, things that work with their growth potential to get things back on track. By the time they're, say, 12 and 90% of that facial growth is done, the options become much more limited. You're usually looking at mechanical tooth movement with braces or potentially even surgery later on because the window to guide the bone growth itself has largely closed. #tag outro.
Wow. This has been incredibly comprehensive. It really paints a picture of how interconnected everything is in these early years. The safe sleep protecting that vulnerable airway, the feeding mechanics acting as this powerful workout shaping the face, and then the positioning and texture work ensuring that growth potential is actually met.
Yeah, it really is a holistic system. And I think the main takeaway, hopefully for listeners, is that success here isn't about perfection, but about awareness and ongoing monitoring. You, as the parent, are the primary observer of function. How does your child breathe day and night? How do they swallow? How do they chew?
And understanding the huge structural impact of those seemingly small things allows you to make informed choices.
Exactly. Choices that are really investments in their long-term respiratory health, sleep quality, even neurological development, because sleep quality is so tied to brain function.
Okay, before we wrap up, our final provocative thought. This comes from digging a bit deeper into the sources, and it pushes the timeline back even further before the baby is even born.
Ah, right. The prenatal influence.
Yeah. We focused entirely on development after birth, but craniofacial development obviously starts way before that in utero. And some of the research hinted that high levels of sustained prenatal stress in the mother could potentially play a role.
Specifically, it mentioned the chronic activation of something called the fear paralysis reflex, or FPR.
Yeah. What is that?
The FPR is one of the very earliest primitive reflexes to develop. It's essentially the body's initial freeze response when faced with a perceived overwhelming threat. It's a survival mechanism.
Okay.
The hypothesis explored in some sources is that if an expectant mother experiences chronic, high-level stress, not just normal daily stress, but sustained significant stress, it might keep this FPR system overly activated.
And how would that affect the baby's facial development?
Well, one potential effect of chronic FPR activation is changes in blood flow distribution. It could theoretically shunt blood flow and thus nourishment away from areas deemed less critical for immediate survival in that threat state, potentially including the developing facial structures like the maxilla and the base of the skull in the fetus.
So less blood flow, potentially less optimal bone formation.
Potentially. It might increase the likelihood of certain structural variations at birth, maybe contributing to things like tongue ties being more prevalent, or just slightly less robust bone development in the midface region right from the start. It's complex and needs more research, but it raises a fascinating question.
Which is?
If the mother's chronic stress state can influence the physical blueprint of the baby's jaw and face even before birth, then maybe effective stress and anxiety management during pregnancy isn't just nice to have for the mother's well-being.
But could actually be the very first step in optimizing the infant's future airway health and craniofacial structure.
It's certainly a provocative thought. Perhaps the foundation starts even earlier than we typically think.
A truly powerful idea to end on. The beginning of infant health might really begin with the mother's well-being, physically and emotionally. Thank you so much for walking us through all of this today.
My pleasure. It's crucial information.
And thank you for diving deep with us. We'll catch you on the next one.